Okay, Karen, I think we will get started. This is Mark Galley, Secretary for Health and Human Services. I want to welcome everyone to our second meeting. This is a monumental commission meeting for the Healthy California for All Commission. In many ways, I'm grateful to our leadership team and all of you and hundreds of people who have written in to me directly asking us to reconvene our group. I know it's a shorter meeting than we had the first time around, but I think the urgency of getting us going again in this critical time cannot be underscored enough. Before we launch into our agenda, I wanted to turn it over to Karen Bloomer from our consulting team to review sort of the protocols for this meeting, a little bit of what we talked through in the first meeting, but then of course doing this through Zoom is quite different, and we just wanted to go over that. So Karen, please take it away.
Thank you, Dr. Galley. Good morning, all. Yes, if those of you that have a screen, and you can see the slide here that goes over sort of the high level, how we will take input today, and I'd like to walk through that. First, this meeting is being recorded, so we will have a video and audio record of the meeting. Commissioners, you are considered panelists in this webinar. That gives you the ability to mute and unmute. And of course, if you have a camera, to be on video, which we hope you will opt for. Please keep yourselves muted when you're not speaking, just so we don't have a lot of background noise. In terms of giving your input today, commissioners, we will be at various points of the meeting, of course, soliciting your input. What we'd like you to do, just so that we don't all talk over each other, is for you to use the chat feature to let us know that you'd like to contribute to the discussion. The chat feature is at the bottom of your Zoom screen. There's a chat icon, and feel free to just walk yourself through this as I'm describing it if you'd like to practice. You'd click on the chat icon, a text box would pop up, and right there at the bottom, there's a place for you to type something in. You could just say, want to speak, or I have a comment, and then press return, and that will be our log of commissioners who would like to speak. We also welcome commissioners to use that chat feature for any additional written comments. Perhaps you don't want to take the time to speak, but would like to embellish or echo something that you're hearing. All of this will be part of the public record. Also, please understand that as we call on commissioners to speak, it may not always be in the order that you'll see in the chat queue, because we do want to ensure to maximize voices from those on the commission. And again, feel free to practice with your chat feature if you like. For members of the public, you are considered attendees today. We see 220 of you, which is wonderful. There are 3 ways actually that you can contribute your feedback today. First is you can use the Q&A feature for written comment during the meeting. That is available via an icon at the bottom of your screens called Q&A. If you click on that, and feel free, of course, to practice this as I'm describing now. I see we already have a few. You can click on Q&A and you can type in a comment or a question, and that will also be part of the public record today and part of our meeting summary. We won't be in a position to answer each of your comments or each of your questions. Rather, this is just the mode we're choosing for written comment. But please do feel free to use it as much as you like so that we can include it in the record. Another form of input from the public that we are inviting is via email. So especially if you have a long written comment that you'd like to provide, you can email us at healthyca4all@chhs.ca.gov. So we welcome public comment that manner. And then we also want to make sure everyone knows today that we are extending the meeting for 30 minutes for those that can stay. We know that some commissioners, for example, already had obligations, but for those that can stay and for members of the public that can stay with us, we will transition to a verbal public comment period. And I'll wait until that period to go through the directions so that you don't forget by the time we get there. And at a midpoint during this meeting, I will be summarizing the written public comment that we've received through the Q&A at that point. All right, at that, I will turn it back to Dr. Galley. Thank you.
Karen, thank you so much. Before I turn it to Dr. Chen, I just wanted to spend a minute welcoming all of you back. And many of you from the public, this is your first chance to join us because the world is quite different than the first time we had this meeting. This creates an opportunity that frankly has become normal for many of us, zooming into a meeting, having a very structured and important conversation, not in person, but virtually, is really one of the innovations that have come over the past few months. And I want to acknowledge, before we dig in to our agenda, that the pause that we put on the commission was absolutely, and I know all of you know for good reason, what has happened in our state and our nation and our world over the past few months is nothing short of incredible, nothing short of riveting. And I remember in our first meeting, I had to take about a 90-minute pull-out myself, unexpected, to be able to deal with what was then just really the beginning. Repatriation flights, cruise ships coming into our ports, and really working with the federal government on doing that safely. And that seems like years ago, frankly, that we were just worried about getting people back on an airplane from China or a cruise ship from the Asian Pacific and into California, bringing Americans home. And what has happened across our nation and to not just our healthcare delivery system, but to our entire economy, really is important and grave to the conversation that we're having today. And the need to pick this conversation up now is even more important. I think I call COVID the great unmasker and the great accelerant. And what I mean by that is it's unmasked parts of our system that were wobbly and crickety anyhow. It's unmasked the deep disparities based on race, gender, ethnicity, many other determinants that we are seeing come out in our data every single day. You cannot overlook the recent, quote, civil unrest and demonstrations around racism and race-based policies and programs in our nation and in our home state of California and our home communities and cities that punctuates the need for change in all areas of our work, and not least of which within the space of healthcare and healthcare coverage, and the need to have this structured conversation deeper and broader around where are we heading with healthcare reform in California, and how is that going to build into a national narrative, I think is critical. I really do look forward to this. I've been thinking quite a bit about as we try to determine how we limit transmission and spread in all of our communities and lower income communities in particular. How does this conversation about how does it make sense to necessarily have all of our healthcare coverage or most of it anchored to employment when we see overnight millions of Californians and tens of millions of Americans lose their coverage in almost a moment's time. So I think the importance of today and what we're starting, I know it's a shorter meeting than people were accustomed to, but the team certainly felt like getting us started now was more important than waiting it out till we had the 6 or 7 hour block of time that might have taken more weeks in order to schedule. So, you know, I know that many of you have thoughts and comments, and I do just want to say one last thing, that in planning this meeting, there was a lot of emphasis on trying to get it scheduled rather than wait. And so the ability to add on 30 more minutes for public comment, given the real outreach and frankly outcry from the public to have this effort restart, I think is great and important. It's never enough. 30 minutes will go fast. We wish we had 30 hours, but we promise and are committed to continuing to build in the feedback, not just from the commissioners, but from the broad public that's joining us today. And to all of you, we're grateful for your time and energy and focus on this topic. You know, I'll go through some of the rest of our agenda in a few minutes, but I wanted to turn it over to Dr. Chen to take care of a couple of important frames for our work today and moving forward. So Alice, please take it away.
All right, thank you, Dr. Galley. I think we all, for those of you who joined us in January, it does seem like a lifetime ago, we did review the structure and purpose of the commission, and just wanted to briefly remind people that the commission was established, before COVID was even on the radar, to provide the governor and legislature with options and recommendations on really advancing a healthcare delivery system in California that provides coverage and access through a unified financing system, including but not limited to single payer. And I think in the context of COVID, next slide, do I drive the slides? The principles that we landed on are more resonant than ever. In the context of the disparities that we see, the context of, as Secretary Galley mentioned, reliance on employer-based insurance, fragmented delivery and financing system, accessibility, affordability, being an equitable system that addresses front and center the disparities that we see, one that's high quality and universal, is more critical than ever. Next slide. And just to recap that the role of the commission is really advisory to the governor and legislature. People on this commission were chosen for deep and broad expertise. We are really counting on them to provide valuable input into policy options, and really exploring the implications, again, unprecedented pivot. And we're really hoping and trusting that our commissioners are going to be our partners and lead us in thinking through how to proceed. The commissioners do take advisory votes on potential recommendations, do not have decision-making authority for the state, because that rests with the legislature and governor. I think that's the last framework slide. So I'm going to go ahead and do the roll call for the commissioners. I'm going to pull it up here. And so when I say your name, just please say hello. I'll start with Secretary Galley is already here, having opened us. Carmen Comsty.
Here.
Jenny Chin Hansen.
Here.
Bill Shao.
Here.
Rupa Myra.
Maria, here.
Maria, apologies. Bob Ross. Not sure if Dr. Ross has joined us. Richard Scheffler.
Here.
Andy Schneider.
Here.
Sarah Phlox.
Here.
Janice Rocco.
Here.
And Tony, actually, and Tony won't be joining us. Anthony Wright.
Good morning.
Peter Lee.
Here.
Don Molds.
Morning.
Assembly Member Wood.
Here.
Excellent, thank you. That's the first time I've done roll call via Zoom. That went very, very smoothly. Thank you all. I'm going to turn it back over to Dr. Galley to review the agenda.
Dr. Chen, thank you for reminding us the frame and the commission's role. We're going to dig in first to the draft environmental analysis report. Then we're going to discuss the commission's work plan going forward. And, I know that from a timeline point of view, that the commission began with some clear timeline targets that were driven around getting our reports in at a moment in time, and a moment in this governor's term where we could be very action-oriented with the focus and the recommendations and the advice. I think because of the pause, we want to be very clear that our intention, although the timelines are important, and frankly, the outermost timeline for our final report may be the most important, but ensuring that we create enough space for commissioners to provide meaningful feedback to the reports is important and valued. That's the whole purpose you agreed to do this. That's the whole purpose the governor and our legislature partners asked to put this together. So I want to be clear that although we're driving towards timelines, we may certainly agree to add, a few more weeks, maybe even a month more, especially to the first report, to make sure that we get enough of your feedback built in. So with that, I'm going to turn it to Marion to walk us through the overview of our environmental analysis report, and I'll look forward to the conversation on this important first step report.
Thank you so much, Dr. Galley, and it is a pleasure to be with you all today. I am Marion Mulkey, and I'm a member of the consulting team led by Dr. Andy Byman of UC San Francisco that's supporting the commission process. Because I helped assemble and edit the draft environmental analysis, and because I'll play a role in coordinating its revision to address the feedback that we hear from members of the commission and the public, I'm offering today's overview of the report. Next slide, please. So to ground our conversation, and at the risk of stating the obvious, the emergence of the COVID-19 pandemic and the related economic downturn has substantially influenced the commission's work and the work of the consulting team in support of it. Obviously, as we've already discussed, the timeline and the format of the commission meetings has shifted, and that's what's brought us here today. In addition, of course, the pandemic and the related strains on the healthcare system, on coverage arrangements, and on the overall economy has caused us on the consulting team to revisit our analysis of the California healthcare environment. It was the consulting team's task to offer a snapshot of the current context for healthcare delivery, coverage, and financing. But of course, that environment has experienced a true shock with the implications of the pandemic continuing to play out. And finally, of course, the pandemic has informed some thinking by the consulting team and by Dr. Chin and Dr. Galley and others at the agency regarding the work plan and the next steps in the process by which we move forward. And you'll hear more about that from Dr. Byman in our second agenda. Next slide, please. So the goal of my brief remarks to you today is to provide a synopsis of a set of interviews that the consulting team conducted with the commissioners, and then to provide an update on where we are with this first deliverable, the environmental analysis report that is in process. Next slide. In terms of commissioner interviews, we originally, the consulting team conceived of these interviews as a way for the team to engage systematically with the commissioners and draw on their wisdom, building on the input that they were able to offer at the first meeting in January. We thought about this as a way to continue and deepen the conversation, and it was indeed useful for that purpose and allowed us to sustain our work even as the shelter-in-place order prevented in-person meetings, including the previously scheduled April commission meeting. Commissioners were interviewed by a pair of the consulting team members in either March or April of this year. When I talk about the consulting team, I'm talking about the group led by Dr. Byman of UCSF, and the 6 of us who conducted these interviews in pairs were myself, Andy Byman, and Rick Kroenig, who brought content expertise, along with Eric Douglas, Karen Bloomer, and Bobby Wunsch, who helped elicit themes from across the conversations. So we asked each of the commission members a series of questions that related to the priorities, the commission process, and what we called the essential groundwork that would be needed to move California toward unified financing. We have done our best in the current draft of the report to incorporate the feedback we got from commissioners, and we look forward to hearing more today. in terms of how well we've gotten to that and what additional refinements we might want to make. As we go forward with our charge, which is, as I know you're all aware, to identify options for steps California can take to prepare to a transition to unified financing system, including but not limited to single payer. And we're particularly eager to advance the conversation today about what those steps look like within the context of the pandemic and the current realities of the healthcare system. Next slide, please. And now a very brief overview of what we heard in the interviews related to the path toward unified financing. So a small number of commission members encouraged us to think very boldly about one major leap toward unified financing. For example, identifying the legal steps and a specific policy proposal path to move toward single payer or some other unified financing approach. However, most commissioners emphasized what some came to call bold preparatory steps, approaches that would lay the groundwork or be foundational along the path toward unified financing. These were all approaches, again, back to Dr. Chen's overview that advanced those key values of affordability, accessibility, equity, high quality, and universality that were central on everyone's minds. Needless to say, because the kinds of shifts toward unified financing or the major shifts in payment or delivery of healthcare services are so complex, not surprisingly, the input and the suggestions we got from members of the commission were diverse and included a number of different types of steps that might make sense in the views of the commission members. So a sampling of some of the ideas that were raised and proposed to us. Some of the steps that were suggested, including looking at existing state-sponsored programs and making steps toward greater alignment along the dimensions of purchasing approaches, quality reporting, provider payments, those sorts of things. Another set of suggestions involved focusing on job-based coverage, regulatory or other requirements that would better address affordability and make benefits more consistent within job-based coverage, since of course that is a major source of coverage today for California. And then a final grouping of suggestions involved beginning with a subpopulation. So a big leap would of course involve a single approach for all Californians. There was some thinking among some members of the commission that beginning with a subpopulation, for example, children or families with children or the population other than those eligible for Medicare might be a starting point. So again, not surprisingly, this wasn't definitive. There were many great ideas. We took those all into advisement and have tried to capture the gist of them in the current draft of the report. Next slide, please. An overview of the structure of the environmental analysis report. It is broken into 3 sections, and those sections reflect the charge that was provided to the commission in its original statutory context. The first section describes the current state, includes matters related to demographics, sources of coverage today, healthcare delivery and financing. And we did our best to incorporate some early observations about the impact of the COVID-19 pandemic. Needless to say, those implications continue to unfold. This is the longest portion of the report. But certainly we would acknowledge that many of the data points in there are well known to the people on this call and the members of the commission. There are a few new data points that are included. I would just call out one as an example. Table 2 on page 49 shows increased consolidation of physicians within healthcare systems. In particular, the fraction of physicians in California healthcare systems grew by almost 20 percentage points between 2016 and 2018, with particularly rapid growth in the 10 largest healthcare systems. So that's section 2, a background and overview of the current state. Section 2 involves steps to prepare to transition to unified financing. And this is the one that is most directly linked to those interviews with commissioners that I previously described. And it is the one that we are hoping you all will particularly focus on in the feedback that you provide to us on this first draft. Section 3 is responsive to another portion of the legislative charge, options to expand coverage along with potential funding sources. I will note that acknowledging the post-COVID budget realities, this discussion is fairly brief, and it primarily offers ideas that either arose earlier in this year's budget cycle before some of the economic effects of the pandemic kicked in, or ideas that have been proposed by other organizations and voices within the California policy context. Next slide. And so I will draw my remarks to a conclusion just by offering some notes about the process for assembling the report and the next steps as we see them. First, in terms of the report, as I said, a lot of the data in section 1 comes from the rich diversity of research and resources available in California. There's work cited from many colleagues, distinguished colleagues from all kinds of different organizations and sources. I would call out in particular the work of colleagues on the consulting team from UCLA and the UC Berkeley Labor Center, who follow coverage trends through the CalSIM model, some of whom are on today's call. The current draft that you see has been through a couple of iterations. It has benefited from input from Dr. Chen and her colleagues at the Health and Human Services Agency. And we also have received some comments subsequent to this draft that we will work to incorporate. So it is definitely a work in progress still. In terms of process, the commissioners themselves received a draft report about a week ago from Dr. Bindman. Members of the public have had access to a draft as of yesterday. As we indicated earlier, comments can be sent to the Healthy California for All at chhsa.ca.gov email address, which we'll put in the chat line, and we will do our very best to review and incorporate those as we receive them. Just the final note before I hand it back to Eric Douglas, our facilitator. This first report was intended to lay groundwork and to kick off the conversation. Clearly, the Commission will engage in subsequent discussion and analysis that leads to a more comprehensive report, the one that's due in early 2021, that will describe how a unified financing approach could be designed for California, and will certainly include a robust assessment of the implications of unified financing for access, affordability, equity, equality, and universality. So that's where I wanted to conclude my remarks, and I'll hand it back now to Eric Douglas, who will invite your feedback on one aspect of the report.
Thank you very much, Marion, and hello, everybody. I first just want to take a quick pause and welcome Dr. Ross to the Commission meeting. Dr. Ross, hello. It's nice to see you earlier, and I saw your photo, your video, so good to see you joining us. Before we launch into our discussion, just a couple of reminders about the way in which we want to facilitate the queuing up of comments. We want to use the chat feature. And so at the bottom of your screen, if you haven't already found it, the chat feature, if you open that up, it will enable you to just send a message saying, I want to make a comment, or I have a comment, and I'm monitoring that, and I can see who wishes to speak. So, and I would just ask also that while you're not speaking, if you could mute yourselves and then unmute yourself when you make a comment, that would be very helpful. We have people standing by to re-mute you if you forget to do that. So not to worry, but please do unmute yourself when I call your name to make a comment. So I'm sure you have lots of questions as well as comments about this report, but we thought a good framing question for our discussion today would be this one that's on the screen right now, which is, within the context of the pandemic and within the context of what you just heard Marion review in the report, we'd like to hear what you feel, what preparatory steps you feel toward unified public financing are most opportune, most crucial to take at this time. So I will ask you now to use the chat feature and let us know if you wish to speak. And I am awaiting an eager hand to put their hand into the chat feature. Well, perhaps because I don't see anybody putting their hand up right away, I know Andy Schneider, you're one of the first people to join us this morning. And so just purely on the basis of being here early on, I'd be curious to know if you have particular thoughts with regard to what would be the most crucial preparatory steps to take toward unified public financing.
So no good deed goes unpunished? Is that what's going on?
Exactly.
Okay. So, you know, it's a little hard from Washington, D.C. We have our own set of issues. And I think I'd be in a better position on this particular question if I were in California. But the one thing as a general matter I'd say is as the chaos unfolds, you know, health status, health access, healthcare delivery system, state budget, local budget, unemployment, as that all plays out, to me, the first preparatory step would be try to maintain the coverage that's working and keep the providers afloat who are doing a good job.
Mm-hmm. Great, thank you.
That's it.
That's great. And let me just go into the queue now because I see people have queued up to make comments. And so I think Sarah Fox, your hand was up first, or you mentioned you have a comment first. So let's hear from you.
Thank you, and hello to my fellow commissioners, and hello to the public. I have lots of comments about the report, but I just want to focus this comment on your question. The COVID pandemic, I think, for me, has really, as Dr. Galley said, unmasked our healthcare system and shown how reflective it is of the racial and economic injustice and inequities in our society at large. It's so clear in who's been hit and the communities of color that have been hit by the pandemic, and also just in the supplies, the resources, the PPE, all of that is not available in public hospitals, safety net hospitals, available to low income or communities of color. And so it really drove home to me that as we move towards unified financing, we need to figure out equitable funding, access, and an end to health disparities. Like as we figure out the funding and the financing, we have to figure out how to make our health system more just. Mm-hmm. And that also goes into my other comment, which I'm going to hold, which is on just the overall cost and price of the system, which I don't see my comments reflected in this report, but I'm going to hold that and just say that we really need to think about how we make the healthcare system able to serve the population of the state more equitably as we move forward towards how we finance it.
Great. Thank you very much, Sarah. So the next speaker is Carmen Comsty.
Hi, and thanks everyone. I'm glad that we're back here. I just want to quickly, to comment on the pandemic. I believe that the pandemic has shown us we have to take the big leap right now and to single payer. And that, I was one of the commissioners who said that we need to take the big leap. So I don't know who said that we shouldn't, but I'd like to have that conversation in public in front of all of you so that we can actually really understand what are the concerns and dive deep into these issues amongst each other. We owe it to the millions of Californians who have just lost their employment-based insurance to take the big leap. Millions have lost income in the past few months. They can't afford out-of-pocket payments. They may not be eligible for Medi-Cal. They may not be able to afford covered California plans. And the pandemic has reinforced what we already know, that private health insurance forces millions to live on a healthcare precipice. And we need to take immediate steps to take private insurance out of healthcare. And further regulation and reform of insurance, which I've seen in the report, is not enough. As Sarah said, COVID clearly showed our fragmented system is unable to allocate resources based on need. Nurses and other healthcare workers have needlessly died. People I represent have needlessly died because of our healthcare corporations' reliance on just-in-time supplies. Black and Latino communities have seen disproportionate deaths and infections in California because our healthcare system is unable and has been unable to get them the healthcare that they need. I think we need to wake up here. We can't just be spinning our wheels. And I really wish that, we need to move forward quickly right now. And what we can do, I know that I don't have that much time to speak here, which is unfortunate. What we can do as bold preparatory steps, if you want to call them that, is designing a unified financing system, drafting and submitting a federal waiver application. We should be drafting state legislation for a single payer program. We can base that off of HR 1384, which was introduced in Congress this session. We can identify non-federal funding resources. We can really ask ourselves, how do we redirect monies from law enforcement and corrections budgets into healthcare? How do we redirect funds from corporate tax subsidies into healthcare? We can be doing all these very important steps, but the process of this report has kind of blown that all over. And we really need to focus on making sure that we have the advisory committees that we need to get expertise from people that know and about this, about all these issues that we were supposed to talk about in the first report. And we need public participation, not more corporations telling us what we already know their position is. I'm going to stop there. I have a lot more comments, but I'm glad that we're finally meeting again.
Carmen, thank you so much for those remarks. And I think we all appreciate exactly where you're trying to lead us. I think next up on the list is Anthony Wright.
Hi there. I also, first of all, I just again appreciate being with all of you again. This conversation is incredibly important, especially at this time, and I appreciate the question. I too have a lot of comments on the draft that I will submit in writing, but I think that some go directly to this conversation, which is that the dislocations that the COVID-19 has, it's the issues that we knew, but have just been highlighted even more extreme. I think similar to what my other colleagues have said. I mean, I think in terms of, and I do think that if we look at the environmental scan part of this report, it is an impressive summary of many of the key issues in our healthcare system, and I appreciate putting it all together. But I think there are some gaps that I think we can fill in. One is around consumer experience, that it is just how people experience the system, both over the course of their life, having to change doctors and plans, and because of all these, because of their job circumstance, where they live, etc. How they and that's only magnified in this situation when there is so much disruption in the healthcare system, how they're experiencing it. People make life choices based on healthcare and health coverage, and I would like to see a portion reflect on that. I think that also goes to that not everybody experiences the healthcare system in the same way, and different populations, including, and I think that those issues of race and ethnicity, of LGBTQ status, of income and others, is something that deserves is included in the report in different places, but I think deserves its own section to really go into health equity and how, and I think that's now more than ever that needs to be really spotlighted as how people experience our healthcare system, and then the very question of the critique of the system with regard to how it is driven by market and profit motives that are not aligned with better outcomes, better lower cost, better quality, or anything like that. And I think that is something that the report hints at in its conversations about price and consolidation. But I think to just go directly at that issue, because I think that's the problem that we're trying to solve for, and that has become even more explicit in an age of COVID, where again we developed a system based on certain market systems and efficiencies that were unrelated to public health preparedness, that were unrelated to the things that we needed to do. And so I think if the environmental scan is the problem statement, we need to lift up those as the problems that have been exacerbated by the COVID-19, always existing, always something that we were focused on, but that need to address. I do think that as we go into the question of the solutions, which is a shorter statement, and whether they are the immediate steps that we take literally in the next couple of months, or the issues of what is possible when we have a potentially a different federal environment, and how do we be ready for that? I do think that we're going to need more time to really more commissioner input. Not more time in terms of like years, no, like in terms of now, really focusing in on beefing up those sections. There's a lot more we can do there. There are even just legislative proposals that we've had on the table in the last couple of years that are not reflected in here that I think are important building steps. I want to talk more about that, but I just wanted to say that I think that there's a lot more we can do on sections B and C on steps and on coverage expansion and on getting to the big leap, that I hope that this is not this shouldn't be the only time before we flesh that out. We're going to need to beef that up more. Thank you.
Thank you, Anthony. So next up we have Rupa Maria. Rupa?
Hello, commissioners and everybody, consultants, and the public who's joining us. I'm speaking today from Ohlone Territory of Huichin, now known as Oakland, California. I just want to say I've been very busy, as I know Alice has been as well, on the COVID response at UCSF, as well as now the twin pandemic of police violence that has displayed for us all the glaring impossibility of health for Black, Brown, and Indigenous people. I am also firmly behind going for a big leap. We're in the midst of public health crises facing us. It is not time for incremental change. It is time for bold, visionary change. I've been following the thread of Q&A that the public is speaking up on, and it's overwhelmingly people speaking to the need for single-payer healthcare. It's overwhelmingly speaking to the need for their voices to be included in this commission, which I agree. I think it's an egregious error that we do not have the public engaged in this commission. So it may be as an advisory group, in addition to healthcare industry and providers, we should have a advisory group of the public who are impacted, especially perhaps one specifically for Latino and Black and Indigenous people in California who are the most impacted by our fragmented healthcare system, and let them offer us some input that we could follow. I think I will be also submitting my concerns about the report to our consultants. I feel like there were certain gaps that need to be addressed, such as just the complete invisibility of Indigenous people in the first analysis of demographics in California. And we know that Indigenous people are also suffering really hard impacts from COVID. I think that COVID also shows us that we cannot rely on our federal government, no matter what the political scenario is. We can't rely on them for the things that we might need in the midst of climate shocks or health shocks, and that we need to build a resilient system here in California, independent of whoever's in the White House. So the more rapidly we can build that now, the more we can secure the health and safety and well-being of all Californians, irrespective to what political milieu is in Washington. I would like to say also that COVID has exposed to us the many glaring problems of private healthcare insurance in our country. So the recent New York Times article from the 8th of June showed that hospitals were receiving bailout money, CEOs ran away with the money, and doctors and nurses are being laid off. So in the midst of a pandemic, it's like giving your military a pay cut in the midst of a war. We have doctors and nurses getting pay cuts and getting laid off. We still don't have enough adequate PPE, and we're expecting a surge in August and September. So this shows us that our priorities and financing are off with our current system, and is really an urgent call to move to single payer now, to set that structure up now. So that those are the things that I will be mostly concerned about. I think that the next steps that we could take right now would be to weaken the private sectors, to make recommendations to weaken the private sector's ability to set costs and to discourage the profit-oriented nature of healthcare in California. If those things are weakened, we can start shifting our priorities to actually unifying and providing better healthcare for everybody. I also did not see several of the comments I made in the report, and so I will be addressing that separately. Thank you so much.
Thank you, Rupa. Thank you for those remarks. Jenny Chin Hansen, I believe you're up next.
Yes, thank you very much. And thank you for the team for the report that has come out. You know, the element of COVID, as noted, is unprecedented, but it drew me to the thinking of the timing of taking bold preparatory steps. Not obviously, on the one hand, on the scale of what the UK faced, or Britain faced at the time of the end of World War II. From the ashes, technically, the National Health Service came about. So I could see that with the system that we have firmly in place at the moment here in the United States, there's something in between that I have thought about given the COVID circumstance. I just would also affirm many of the comments that were made by my previous colleagues about the inequity, but I also think that it's an opportunity to benefit from the OECD reports of many of the other countries that have redistributed their spending in the area of health and healthcare that includes public health. And in this process, public health kind of writ large as well as writ small on the details of what helps a population have the amount of preventive care, meaning basic food and shelter and elements that are about health. And going back to that, since we have sensed that the large amount of money that we spend is oftentimes on the medical side, whereas health and health care well-being is actually on the other 80%. So I just want to underscore the comment of taking public health, both safety and well-being as a major element here, so that there's a basic sense of stability and dignity. And the second comment I'd like to make is the opportunity not only for the institutional focus of high prices, but to really think about the workforce in a very different way. This is shown with some of the exceptions and modifications that have been made during COVID. I think it's an important area to take in greater detail to see whether there are areas of competencies that could be shared more fully and formally, both with current health providers, but also the community at large. And it was cited that promotores, community health workers, that workforce is identified as the need and hugely growing. And so my last final comment is, if we could move toward a principle of the commons, basic services, and basic access, which I think is kind of a beginning of a decent health and well-being society, and using our money in a more distributed manner, as well as providing access to assuring accountability and closing disparities. So bottom line is I would support a bold journey on this path at this time, using this major disruption to allow an opportunity for disruption to make sure that people have greater access as well as greater well-being in this process. Thank you.
Thank you, Jenny. Bob Ross, you're up next. Before I ask you to make a comment, I just want to, for the public who are listening in on this conversation and who wish to make an oral comment, we are going to be extending this meeting for 30 minutes, and that will happen between approximately the hours of noon and 12:30. So there will be an opportunity for oral comment then. There is also the opportunity to give the comment in the Q&A feature, as well as to send it to the email address, which is listed in the Q&A feature. So we know you really want to make your voices heard, and we plan to give you that opportunity in just a little bit. So Bob Ross, please go ahead.
Yeah, thank you, Eric. You can hear me okay?
We can.
Oh, great. Good morning, everyone. Good morning to fellow commissioners and the public. Yeah, 3 comments. I'll be really brief. Certainly, one of them has already been made, and that is echoing the comments of fellow commissioners about the COVID moment. To Mark Galley's observation of COVID, the great unmasker of structural and racial inequities, and we need to move forward with the social determinants of health and health equity and racial justice more firmly positioned and ensconced in any report. So that's number 1, and happy to help with that in any way either I can, or even wearing my California endowment hat, is anything we can do to help support that. Happy to do it. Secondly, on the issue of the one bold leap versus the bold incrementalism, I would say this. I think that there are those among us, I mean, let's just be honest and candid, there are those among us who joined this commission already decided on what we want to see as commissioners, which is fine. That's not at all a criticism. And then there are some of us who have not actually made up their minds on that, single leap versus bold. And as someone who falls in that camp, I would really like to see a picture painted about the kind of single bold leap that our fellow Commissioner Constey has called for. What would that look like? What would that mean? What would it entail? Economically, financially, politically? Can someone just sort of paint the picture? And certainly with the sort of bold incremental kind of approach that apparently several commissioners have spoken to. So I would just want to get educated on both of those fronts. What is the single bold leap towards single payer? What would have to happen? What would that look like? What would that look like? And so I don't know, Mark and Alice, how that could be painted, but I honestly feel like I don't have I have a vague sense of what that would look like, but not a precise one. And I would like to be educated going from vague, and I think I know what it means. I'm not entirely sure what it means, but I'd love to be educated on that. And then the third point I'd make is the matter of community input. And I do want to find a way, Mark and Alice, that we can just get more community input, structured input. And I'd like to find a way of getting outside of the circle of health reform advocates who are pretty sophisticated about this issue, and more into communities, particularly vulnerable in communities of color, who are not necessarily true and tried health reform advocates. I just would want to get, particularly in the wake of COVID-19 and what has happened with with George Floyd and the matter of racism, I'd like to figure out a way to provide an entry point for community-based organizations and community-based activists and leaders who are not necessarily health reform savvy to find their way into this conversation and hear from them as well. So thank you.
Thank you, Bob. So next up, in order, we have Janice Rocco and then Richard Scheffler and then Jim Wood. So Janice, look forward to hearing your thoughts.
Thank you. Like Dr. Galley started with, the pandemic obviously has had this unmasking role for many people throughout the state and the country. Those of us who've worked in healthcare for years are seeing some of it a little more clearly, but it's shining a light on problems that we've known have long existed. But when you have millions of people who lose their jobs at once and whose healthcare is tied to those jobs, you have millions of people in the middle of a pandemic who have to transfer into a new healthcare coverage system, whether they're electing COBRA, which is not the common route, or moving into Medi-Cal, or looking for a plan through Covered California. Right in the middle of the health crisis, they're hoping that there aren't paperwork errors or time lags, because millions of people are having to change their health insurance coverage all at once in the middle of a health crisis. Those are not things that should happen. We should have a public health system that is serving all of the public, and through a single financing mechanism. In my mind, the ACA moving to a situation of expanded Medi-Cal coverage and the creation of healthcare exchanges like Covered California was a big change, an important big change that took a few years to stand up. And now it's time for that next big important change that will take a few years to flesh out and stand up. But I do think it's time for a big leap. At the moment, we have health insurers who are collecting premium from each of us on a monthly basis, or our employers. And we're not necessarily able to use most of that coverage right now. So it's going to be interesting to see if they have a windfall profit year, because most of us can't go to the doctor right now unless we have an urgent need. So, I do think that the disparities that we've long known about are worse right now than they have been. And I think that when you're in the middle of a pandemic, there are so many ways in which society has changed over the last few months, and we, in many instances, are seeing that we are all in this together, and that we have to work collectively in order to get through this pandemic and not to even infect one another. And our health system needs to be that situation of, we are all in this together. We all get the same coverage. It's one through one financing mechanism. And so I do think it's time to put the pieces together over the next few years so that we can take that next big leap.
Thank you, Janice. All right, so next up is Richard Scheffler.
Okay, good morning, everyone. So the pandemic, I think, changes everything for this report. And I think it's not a sidetrack. It needs to be the center of focus. And in public policy, when we have a crisis, that's also an opportunity. So as sad as this pandemic is and the lives we've lost and the health impact, it also gives this commission, in my mind, an opportunity that it didn't have before to do something that's bold and big and hopefully useful in solving a lot of the healthcare problems that we've talked about. I'm looking at the screen at this question of unified financing, which has puzzled me for a while, but I take it's being used by the commission and the consulting staff to mean putting different pots of money together in one place, from Medicare, Medi-Cal, the ACA, commercial insurance, and anything else in one place, and then figuring out how to use that money. That's a very complicated issue because each of those pots of money comes in different ways. Medicare money comes, from payroll tax, and Medi-Cal comes from the state, and so I could go on and on about that, but I think we need to tackle this question of what we mean by unified financing, and also where that money originates, because it doesn't come from Medicare. The Medicare money comes from payroll taxes and other forms of financing. So this is a question that has two layers to it. The important thing about COVID in my mind has been really the lack of the financing of the public health system. What we found was, and I think can be made stronger in the report, is that it's been incredibly underfunded. It's decayed, and it's getting worse, not better. And it needs to be thought of in this financing question. We need to think about adding the financing of the public health system. I think it's disgraceful that in certain counties or certain areas, people were able to get tests, and others, they couldn't get tests because of the financing that the particular public health system had, or what the particular local government was willing to spend in their own money. I don't think it's fair and equitable, and I don't think we can tolerate those kinds of differences when lives are at stake. Same thing in the hospital system. We can't leave it to the fact that certain hospitals might respond differently and be willing to spend more or less money on buying the equipment they need, the ventilators, for example, and others. Hospitals would like to do it, and they don't have the financing to do it. But the big systems are more able to do this, and the small systems, particularly in rural areas, are not. So I think the financing issue needs to be broadened, and we need to think of it in the sense of an opportunity to really finance healthcare in its broadest sense, and most importantly, to integrate the financing issue coming from the public health sector, which we found out in this pandemic was absolutely key to saving lives in California.
Mm-hmm. Thank you, Richard. Assemblyman Wood.
Yes, thank you. Thank you very much. And I appreciate the comments that have been made. And most recently with Mr. Scheffler, I think you nailed some really critical items. I want to paint a perspective for people that may not be terribly welcome, but it's important that we actually consider this. We are facing up to a $54 billion budget deficit. We have 13 million of our 40 million Californians on Medi-Cal, with the likelihood that another million will be joining the ranks. We are seeing proposed budget cuts to senior services, to our safety net providers, and fees for reimbursement rates for doctors, the cutting of services throughout the Medi-Cal program. And so just within that third of our population, or more than a third of our population, we're struggling to keep the infrastructure going. I have a represented district that has a large number of small hospitals. I have 6 critical access hospitals of the 34 critical access hospitals in the state. Our infrastructure is on the verge of collapse in some of those areas. And so one of the things that, for me, it's hard to envision taking a bold step right now without stabilizing the infrastructure. I lack primary care providers, I lack dentists, I lack you name it throughout my rural district. So for me, one of the critical things is I think we also have workforce issues that are not being addressed. If we're going to make that leap to single payer, we're going to need many more primary care providers, which we don't have. And so one of the things that I have been an advocate for is pushing for more workforce. We have to have workforce in place to be able to care for people, and we aren't going to have it. I also would push back against the idea that California can go it alone without federal resources. I don't believe that. I think all the reports have shown that we rely on the federal government for about half of the money we need for healthcare in this state. And which is upwards of $200 billion a year, I can't even conceive of us not having the federal resources to provide care for people. So I'm very concerned about just the basic infrastructure at this point. And we are facing very difficult budget decisions right now, and ongoing the next couple of years are going to be a challenge. Now, does that mean we don't want to move forward with the steps? Absolutely not. But we also need to consider too, I do believe that we will have to go to the ballot for a change in the GAN spending limit. Also believe that if we're going to rely on the public to help finance this, we're going to have to go to the ballot for that as well. And those are preparatory steps. You cannot take the big, bold leap without having some of those things in place. And I would just urge people to think about the big picture from a financial perspective too, as we lay the groundwork to actually getting to where we all want to go. So thank you.
Thank you, Assemblyman Wood. So I and the other members of our team are clearly appreciating the themes around how much the COVID-19 pandemic has changed the game for this commission and changed the game for the charge to this commission to look seriously at reforming healthcare in California. Marianne Mulkey, I'm just curious if, as you've heard the comments from members of the commission so far, whether anything particularly strikes you in terms of themes or takeaways for you as we go back to look at this report and refine it further?
Thank you, Eric. I'm very grateful for all the comments, and I take them very much to heart, particularly those around equity and disparities. And we will do our best to incorporate the comments we've heard today, and those I know will come in and have already been coming in the public domain.
Thank you, Marianne. Well, so now I want to turn over to
Eric, this is Mark Galley. Can I just express chair prerogative just for one moment? And
absolutely.
You know, just lift up the comments that have been made. I think in unison. I think there's a recognition that, as Dr. Wood has said, that there are some real opportunities in the challenge that we're facing, and that a whole group of us is focused on stabilization and figuring out immediately what we can do with the state budget to, as much as possible, hold on to gains made around some of the important issues we've talked about, as well as reinforce certain parts of the system that, as Janice said, you know, we've known a long time, but for many others who haven't been close to this, really unmasked some of those weaknesses, vulnerabilities, and frankly, inequities and disparities based on immutable characteristics. I think that the other piece of it is that this administration is about bold steps and thinking thoughtfully about where we go next. It is not wasted on anybody on the planning team that the COVID moment, if you will, is really one that we can't miss. We can't miss the opportunity to use the impacts that we're seeing and managing as a crisis now as really an opportunity to end up in a better place in the midterm and long term than we would have been without COVID. So I just want to be very cognizant of those comments and acknowledge that we as a commission team and the planning team and our consulting team do have a lot of work to do because the context is quite different. And as Dr. Scheffler said, this isn't the side show or the side conversation. This is the conversation. And I think it can reflect very nicely in where we go and how we plan our next many conversations with you all. Back to you, Eric. Thanks.
Thank you, Dr. Galley. So I want to turn next to my colleague, Karen Bloomer, and ask her to summarize the public comment we've heard to this moment. Karen?
Thanks, Eric. And before I do that, I do just want to reiterate again, because we may have some members of the public who have just joined us, that we are currently taking written comment through the Q&A feature on the Zoom webinar. We are also taking written comment through the email address healthycaforall@chhs.ca.gov. And then around noontime, and obviously we'll have to see how this plays out, but roughly around that time, we will explain the process for requesting to offer verbal public comment, and we will take as many comments from the public that we can within that period until 12:30. So hope that's clear. We'll continue to try to make that clear for everyone. In terms of the public comment we've received so far via Q&A during this meeting, it very much echoes much of what has been said. I think first, let me just describe for now, and obviously my hope is that everyone can be reading the Q&A as well, but the tone is urgent, the tone is passionate, the tone is desperate, frankly. And people feel that this pandemic, again, like others have said from the commission, has revealed that the system is broken. And many of those who have provided public comment via Q&A believe that single payer system is the answer, that it saves lives, that it saves money. And there is a plea to take a leap to building a new system and being careful not to focus too much on preparatory or incremental steps, but to make that jump, whatever that looks like. I would say the other big theme is a request for additional meetings, additional mechanisms for input from different members of the public, from folks that are hurting by the current system that we have, by working people, by people of color, just to hear many, many voices through this process. So we'll be speaking to that later today, and obviously speaking to that in future meetings in terms of what that will look like. I think those are the really big themes so far today.
Thank you, Karen. So I think next up on our agenda is Dr. Andy Bindman to go over the Commission's work plan and to discuss in more detail the plans for the next few months and how we're going to keep advancing this work. Andy?
Thank you very much, Eric. Good morning, commissioners. Good morning, members of the public. Thank you very much for this opportunity to address you. What I'm going to do is to provide you with a short overview of focus groups. I want to provide you with a rationale for those focus groups. In particular, want to, in light of some of the comments that I see being raised, want to also emphasize that these are intended to be focus groups, and it is not in any way meant to be the comprehensive advisory group input to this process. We very much envision community meetings with a broad set of stakeholders and input from stakeholders. But what I'm emphasizing in my comments here today is really just the beginning of a process working with some focus groups that I'll describe in more detail in a moment. I'll provide a description of what that focus group process will look like and how it's envisioned that the Commission will benefit from this process. Next slide, please. So this slide clearly is just a reiteration of what has been said so eloquently by many of you on the Commission, and is reflected in comments that I have seen from the public in the Q&A so far. And really just want to reiterate that we all recognize that COVID-19 pandemic has really revealed gaping holes and inequities in California's healthcare system, that the fragmented financing has resulted in millions of newly unemployed individuals, and that these unemployed individuals are losing healthcare coverage at a time of great need. And that not only is it a very significant problem for the general public, but that at the time that we are relying upon healthcare providers to assist us in taking care of those who are ill from this pandemic, many healthcare providers themselves are struggling to address the rapid shift in service demand while hemorrhaging financial resources, because the business model that is in place really depends very heavily on a steady flow of fee-for-service payments. And as really has been underscored in the comments of the commissioners so far, as well as from the public, this moment really does afford a unique opportunity to consider ways to make California's healthcare system more resilient to external threats such as COVID-19, while pursuing the values of accessibility, affordability, equity, high quality, and universality. Next slide, please. So it's been recognized, and I think comments from the public underscore this, that employers who provide and pay for, in some cases, coverage for their employees, and healthcare providers are key stakeholders in our healthcare system, but they have historically had an interest in preserving the multi-payer system. And so a question was put to us by the California Health and Human Services Agency, whether there was an information known, and could we in fact learn about whether there is an updated assessment from these stakeholders about how challenges associated with COVID-19 have altered their interest and willingness to work with public leaders to build a more accessible, affordable, equitable, high quality, universal, and resilient healthcare system in the state. So the idea would be to have focus groups with some of these representatives to really take the temperature, if you will, to better understand if they have been seeing what has been talked about here, and how that has changed their openness, willingness to in fact be partners in the kinds of change that has been talked about here today. So again, this is not meant to be a comprehensive advisory group input process. That's a separate phenomenon. The word advisory is what is leading to some confusion here. But really what we're trying to get at is that we're going to conduct short-term focus groups, mostly to learn specifically from these key stakeholders who have had historically some of the strongest interest in preserving the multi-payer system. Next slide, please. If you could advance the slide, please. Oh, thank you. So the process that's envisioned is to have two separate focus groups with representatives from the employer and provider communities. Each group is only approximately about a dozen representatives, and these would be held virtually because, of course, we're still living under the conditions related to COVID-19. And we would try to do these quite quickly so that we could complete them over approximately a 6-week period and be done by the end of July. The idea would be that the information gathered in these conversations would be summarized without personal attribution, but communicated back to the Commission at a public meeting shortly thereafter. So we're envisioning that meeting being likely to be in mid to late August. So there's an opportunity to summarize the material and provide it back to commissioners as part of the input, along with a plan that will be further developed in concert with CHHS with regard to a larger community and advisory group input process. Next slide, please. What I've listed here is just some examples of the types of questions that would be raised at these focus groups. Things like what would participants in these focus groups want to know about how unified financing would work? both initially and over time, to feel comfortable that it could work well for them and their organization. What would they judge to be the risks and rewards of a new unified financing approach and how those would balance out for them? And what assurances, what kind of new civil contract would need to be in place for these representatives to feel that they could support or at least not oppose such arrangement? And again, these groups are seen as those that may not have historically been aligned with some of the changes that have been voiced here by some of the commissioners. And so we're trying to get, again, a sense to help inform this process about whether COVID-19 has changed that equation for these stakeholder groups. Next slide, please. In terms of selecting the individuals who would be in these focus groups, we were really trying to think about people who had experience and knowledge of California healthcare finance and delivery. Within each type of focus group, we were looking for diversity across group sectors and across geographic region. And as I mentioned, we are aiming for a relatively a manageable size group. We've identified about 12 people for each group. And I'll show you who has been identified on the next slides. These are the individuals who will be participating in the provider focus group. And you can see that they represent different organizations across the state geographically in terms of providers of different types. And some are from systems and some from individual hospitals, as an example, and so forth. And we've also included a couple of thought leaders who are quite knowledgeable about the provider environment, who would also participate in these conversations. Next slide, please. Includes some of the, the participants from the focus group from the employer side, and again, meant to represent different types of organizations, a diversity of geographic areas and types of organizations that participate as employers in the purchasing of health insurance, and again have involved a thought leader in that conversation as well. Next slide, please. So what I'm going to do here is I'm going to turn the microphone back over to my colleague, Eric Douglas, and really try to ask commissioners for their help about what they would find valuable for us to ask as within these focus groups so that we can better inform you all and the public about where these two key groups are with regard to our process. Thank you.
Thank you, Andy. And so just again, a quick reminder about the process of using the chat function to let us know you have a comment. The thing we most want to hear about from members of the commission is this question that's up on the screen, which is, what would you most particularly like to hear in the way of feedback from these two industry focus groups? So I'm curious if anybody has a particular bent on that or wants to begin the conversation. Well, I see nobody's hands up right away, or I should say nobody in the chat. Oh, there's Carmen. Okay. Carmen, let's kick it off with your comments. Thank you.
So I think for clarity for all those who are watching, we as the commissioners have not had a discussion about focus groups. This is very different than what was presented by the consultant team to us in the interviews, at least to me. because we talked about advisory committees in the focus groups, advisory committees that would be presumably voted on by the commission and decided by the commission. So I have no idea how the individuals chosen for the focus groups were picked. I have no idea how employers and health corporations were picked as focus groups. I think this is absolutely the wrong direction that we should be taking. We should be talking to all these people who clearly are using our healthcare system or have not been able to use our healthcare system in the chat and in advisory committees, and we should be getting those public comments from folks and really digging in deep into those issues that are listed in the second report and the first report. And I think what's very concerning to me is that these focus groups are not going to be public, even to commissioners, from my understanding. You know, I'm frankly not interested in what employers and healthcare corporations have to say, because they've been saying it for decades. You know, I want to hear how Californians who use the healthcare system believe that they can get the healthcare that they need. And you know, we shouldn't be opening up these negotiations with employers and healthcare corporations when we don't need to. I think our priorities here for the commission are completely backwards. And I'm not too sure how you know, us as commissioners can address that, because we haven't been able to have the meetings with each other that I had hoped that we would have done. I'll have others speak now.
Thank you, Carmen. Appreciate those remarks. So just in terms of order of speakers, looking at the chat function, I'm going to ask Bill Shao to go first, and then Sarah Phlox, and then Rupa Maria. So Bill, curious to hear your thoughts.
I'd like to offer two comments. One is to really follow up the one just now. If you're getting the focus group input, I think there's a much more important group we need to input. That's the general public and white general public, the people who are not organized. And my colleagues on the commission already mentioned there are many silent voices. And I think I will urge the commission to do that. And I can tell you, you can do it very cheaply. I had 2 students polling Californians, 1,000 of them, on MTurk for $720. And we got some really valuable feedbacks on what they thought of the big leap forward, and why they support it, why they don't support it, what their worries. So the commission doesn't have to spend a lot of money to use the modern technology to do this kind of polling. Polling the general public as well as special groups, the groups which has been disadvantaged, who injustice have been done to them, including the Latinos and Blacks and poor people. Get their views in and get their experience with healthcare. And I would say that really should be the group we should focus on, besides the 2 other focus groups. As far as asking what these focus groups do, let me just suggest, again, I have my students look into these groups. And actually, the public information, how much money they have spent lobbying in California. And as an academic, we do this kind of work all the time to try to find out what we call stakeholder analysis. You have to ask them, really concrete questions to get, rather than their public position, which is a strategy to misdirect you, give you misinformation, so to actually mislead you. So the kind of question you have to ask is very specific. Will you reduce your lobbying dollars in California if we do X, Y, Z? How much additional dollars you're going to put in to oppose this if we do A, B, C? Otherwise, you're going to get a lot of platitude. That's my advice to you.
Thank you, Bill. All right, so next up we have Sarah Phlox, and then Rupa Maria, and then Andy Schneider and Janice Rocco are queued up.
I mean, I could not agree more with the comments by Bill and Carmen. So I'm not going to reiterate their excellent points of an advisory group of those most disaffected and not served by the healthcare system, and those with no lobbyists would be the most important advisory group we could hear from and focus group. The other point I want to make that's that they haven't already covered is that looking at that provider group, the Labor Federation represents a number of providers. That is the rank and file workers, the quote unquote essential workers, the sacrificial workers who went to work every day during the COVID pandemic, often without PPE, wearing the same gown and mask every day. They are also providers. They just don't happen to be the ones in control or who own the hospitals or run the hospitals. And so I think it would be important when we say provider that we look at the people on the front lines who are also providing care, including in nursing homes, which are the epicenter in long-term care. And so that's one. And then on the employer group, clearly employers aren't the only ones who purchase. There are individuals who purchase coverage. There are workers who pay premiums. There are workers who give up raises to contribute to the premiums, who have high deductibles. Those are all purchasers as well. And so I think in addition to public provider, we need to both expand our definition of both purchaser and provider.
Thank you, Sarah. Next up is Rupa.
I want to echo the sentiments of my colleagues who have already spoken. I would say that the advancing these particular advisory groups first in front of a public advisory group shows perhaps what I would call the undemocratic and disingenuous process of this commission. And I'm very concerned about that. It's also concerning to me that, you know, as one of the few people of color on this commission, that we're not centering the voices and the perspectives of those most impacted by COVID, which we're all talking about like as ideas like, oh, the most impacted people, but then we want to hear first from employers and providers. So this feels completely upside down to me. It feels completely disingenuous, and it needs to be called out as such. We live in a healthcare system in California that is an example of racial apartheid. This is an example of racial discrimination and apartheid in our great state of California. We see the same problem with the criminal justice system. It's an example of racial apartheid. 3 people were just shot and killed by, or 2 people were shot and killed by police. Another woman who was shot at lost her baby. She's sitting in Highland Hospital right now. These systems are racially discriminate. They discriminate. And so this opportunity before us with COVID is to address these systemically. And what I see with this commission step, the consultant step is highly concerning to me. It doesn't feel like the right step. I feel like we should regroup and put the public first, and then we can have these other focus groups. If we have these employer and provider focus groups, I would like to hear, my question for those groups is, what have you done with your health systems to prioritize the lives of Black, Brown, and Indigenous people? And how will you know, different financing structures improve that or not improve that? What we've seen is that the structure of a multi-payer system built into that structure is the disadvantaged health of Black and Brown communities. So COVID is exposing to us what we already know. It's built into the structure of our society. This is a great moment to restructure core aspects of our society. We need to decriminalize our police. We need to defund the police. We need to move those funding dollars into health and well-being and community safety of proven models that do not further traumatize and further lead to poor health outcomes for Black and Brown communities. So I would suggest that the commission, first of all, bypasses the steps, goes straight to the public, create a public advisory group first, then let's hear from the employer and provider focus. And I would also like to suggest to call on my fellow commissioners to release publicly your industry ties. I know it's not required of this commission, but I think the public deserves to know what perspectives we're all talking to. My industry ties don't exist. I serve the people. I specifically serve the Black and Brown communities of the Bay Area and the indigenous communities of San Francisco. And so I would like to see from everyone else what their industries are. Thank you very much.
Thank you. Thank
Hey,
you, Rupa.
Eric,
Yes.
I wanna jump in. This is Mark Galley again. So I think first off, the purpose of the commission is certainly to have important and constructive dialogue on process and content. And so I want to just appreciate the comments and really echo many of them. I think that the notion of moving these forward as a disingenuous process, I think I just want to cautious, those comments with the commission, because I think in total, we want to create a process that is as transparent as possible and seizes this moment. I do think that given the comments, Eric and others on our team, I'm going to say we need to hear the commissioners that have already spoken, really listen to the rest who have comments, but really just at this moment, as chair, say we need to rethink what we put out. Not that they are absolutely the wrong ones, but how do we prioritize some of the other voices and considerations that these first two focus groups do not account for? And really lift up what I think Bob Ross said in one of his first comments was, and Bob and I talked about this earlier, how do we get the voice, not of the health reform advocates that many of us do have conversations with on the regular, but really those who aren't deep into this conversation, that are in those disadvantaged and or communities of color that are deeply impacted with this today. And I will say that the response of the state, of which I've had a privilege of being part of the leadership for on COVID-19, has certainly been busy and harried in many ways, but has remained focused on some of the issues that many of you are highlighting. And the opportunity that we have right in front of us with COVID, and we talked a lot about it unmasking or reminding or refocusing the disparities that many of us have followed and tracked for decades, and these inequities, but also that it is an accelerant for change. And again, the intent of some of those focus groups, we should spend a little bit more time with the commissioners explaining and ensuring that the context is set, and make sure that we take everyone's feedback on how to enrich that. And if the collective will is to dismiss it and go in a different direction, we are certainly open to that and want to hear those concerns and voices as we already have. So Andy and others, I think for the time being, I think we're going to pause on that notion of the focus advisory groups and come back in some setting to figure out how to do that in this broader context and process that's been highlighted by the speakers that have already gone.
Thank you, Dr. Ghali, and appreciate those remarks and the leadership you're showing us today. There are 4 more speakers on our list to speak. Andy Schneider, Janice Rocco, Richard Scheffler, and Don Molds in that order. And so Annie Schneider, I'd turn it over to you.
Well, I thought I just heard in deference to the chair that we were going to table this discussion for now.
I think we certainly heard the chair say that he wants to table the process of the focus groups for now. I was curious whether you had other thoughts about the commission process going forward or what your advice to the commission would be. But if you wish to pass on this comment opportunity, we'll move on to Janice Rocco.
Well, I guess all I'd say is I'm happy to disclose industry ties because I don't have any. I have a sister who's a geriatrician and I have a daughter who's an OBGYN. I was interested actually in hearing what the employers and the providers and the public and other potential focus groups have to say. It seems to me like an efficient way to get more information for the commission decision-making process. I'm particularly interested in the providers who are now going through, in some communities, depending on their circumstances, some perilous financial times. And it would be very useful, I think, for all of us to learn how they feel about things now. When I was on the Hill in 2009 and 2010, the provider associations we were dealing with at the national level were very, very dug in on multi-payer. And they were particularly upset at the notion that a public option or a Medicare type structure would come along and administer prices to them that they weren't particularly supportive of. So I'd be interested now in whether any of that has changed in different provider sectors. That's just an example of how focus groups could be useful, not just to the commissioners, but and not just to our process, but to the public at large. I think it'd be a good conversation. And yes, these are not the only two focus groups.
Thank you. Thank you. Okay, so Janice, you're up next.
Great, thank you. And I appreciate Secretary Galley's willingness to press pause on this and give it some more thought together before we move forward with the stakeholder process. As I was listening to the commissioners who spoke before me, one thing that occurred to me that might be a possible option here is when I think of focus groups, I think of when you bring members of the public together and you ask them certain questions and you record all the answers so everybody can see what they've said before they make decisions. But it's not like a big public process, so people can have a free-flowing discussion together. And then, you're either seeing transcripts or videotapes of it if you're, part of the decision-making body, versus the advisory committees that are mentioned in statute. It would seem to me that, the two groups that were initially proposed today would be more in the vein of, stakeholders who have a financial interest in the outcome, and that the public would want to hear from those folks about what it is they're sharing with the commissioners. The commissioners would want to be a part of that, and that we could have those types of groups have the more public process of an advisory committee where there are a couple commissioners participating, asking questions, and then the public is allowed to participate in those meetings as well, and they're publicly noticed and that type of thing. So that might be one option of having focus groups where you're trying to get a broad swath of public folks to tell you their thoughts and concerns about things, and then the advisory committees more for some of the stakeholders, and that those would be done in public. Thanks.
Thank you, Janice. Richard Scheffler.
Well, I'm going to respect the secretary's call to not discuss the focus groups, though I do have some ideas on it, which I'd be happy to pass on at a later time. What I think dealing with the question of employers and providers and the focus groups, what I'd like to know personally is what did they hear on the employers from the workers? What were their biggest concerns and how did they deal with them? And trying to understand any help that they might have gotten from the local government or from the state government. Was it adequate? Was it timely? Was it helpful? And was it effective? And do they have any ideas of when the next crisis comes? And there will surely be the next crisis. If it's not a COVID type crisis in California, we're used to, fires and earthquakes, and there are going to be many crises. And so this is something that's ongoing. It's not going to go away. What did they hear, and how can this commission report help them on dealing with this? Everybody totally understands that this had a devastating impact on providers of healthcare, but a very differential impact on hospitals. The nursing home industry, I think, was particularly disastrous in COVID and death rates we had, and the state of the nursing home industry, I think, needs to be particularly special focus, sticking with the context of COVID, which is the question that you have. So I'd like to hear from the physicians, of course, but the nurses and other healthcare workers, how they were able to function under this pandemic, and what advice they can give the commission for thinking about a unified financing system, which is only part of the answer, but a structural change in the healthcare system that would help us moving forward. Let me stop there, but to emphasize also that I would like to know if they're willing to give us any comments about how they see the issue of institutional racism in their companies, if they're willing to talk about it, or among hearing from the providers as well, how that affected the delivery of healthcare under the pandemic conditions.
Thank you, Richard. So we have a couple of more minutes for comments from commissioners before we're going to turn to public comment. We have two more commissioners queued up to speak, Don Moulds and then Anthony Wright. Don? Don, you need to unmute yourself.
Apologies for that one. I was going to say most of my comments were related to the focus group, so I'll just be very brief. I agree with a lot of the comments that have been made earlier that this is it is always important to start by hearing from the people of California about how they feel about this. I think when you think about the difference between the climate when we started this conversation earlier in the year and now, and the way in which the problems in the healthcare system have become personal for a lot more people, I think you're likely to get a very different picture of this when you hear from the public, because it's just a lot more obvious to a lot more people. And there may be an openness to some things that were more challenging back in, say, February. So, there are a lot of groups that take the public's temperature on this on a pretty regular basis. I'm thinking of the Kaiser Family Foundations of the world that have been focused on COVID and less on this question, but it would be interesting to think about reaching out to them and seeing if they can be helpful with some of this work. The other comment I was just going to make on the focus groups is, I think I appreciate the comments that have been made earlier about taking the temperature of interest groups for change and that being a second order priority. I think the purpose of these kinds of conversations is to see openings for moving the agenda forward. and in particular, the possibility of working to move forward on multiple fronts. And I'm thinking as someone who's representing large purchasers here of healthcare, about moving forward with the cost issue at the same time that we're moving forward with everything else. I think we all know that that if we can bring down the cost of healthcare, all of this is easier to do. So really kind of thinking about what we're focusing on when we're reaching out to some of these groups, I think is important. And I'll just leave it there.
Thank you, Don. Anthony Wright.
Yeah, Anthony Wright, Health Access. Industry disclosures, we do not take money from the health industry, insurers, drug companies, hospitals, etc. I appreciate many of the comments with regard to the focus group proposals. We share and had communicated some of those concerns, and particularly about prioritizing public input. I would, my question, since we'll come back to that, I just want to just be clear and a question about the timing, which I think also would be helpful for the public that's listening, which is just to make sure that there is that opportunity for that, if there is, and there should be, that further engagement with for a broader set of public voices, that be done prior to the ending of end of the closing of this first report that we're putting out. Again, we have the second report that due in February, but that first report I think is an important one, because it is the one where we can actually start acting on as soon as possible to actually take action, so that we're ready for, if it's a federal waiver or a congressional action, that we're ready if and when that's approved to do that. But I think that there's things that we can be doing quickly, but I think we need to have that input to do that. And so again, my main push is just that I think the environmental scan is something that I think is something that is closer, but I think the work around the other recommendations for this first report would benefit from getting that input from both these commissioners and from the broader public. Thank you.
Good, thank you, Anthony. So the hour is 11:55, and I think at this point on our agenda, we do want to have public comment take place. And so thank you everybody who has offered thoughts from the commission side. So I'm going to turn it back to my colleague, Karen Bloomer, who will facilitate the public comment process. So Karen.
Thank you, Eric. And just quickly, I'll summarize the written public comment that's come in through the Q&A in this last segment. And really the fundamental theme from that written comment is an echoing of the desire to have input from the public and various groups that are not well represented. And as some who don't believe the focus groups are necessary, that the data information already exists on what we need to know in order to move forward. And then as it does relate to the focus groups with providers and employers, some are suggesting that there needs to be more representation of practitioners on the provider focus groups. So just so commissioners and members of the public know that that's what's come in so far. Now we are going to turn to verbal public comment. So those of you that are here as members of the public, you are again on the webinar called attendees. And we have enabled your ability to use the raise hand button on your Zoom screen. So that will raise a hand icon next to your name or a phone number if you have called in. And so we are going to refer to that for public comment. I will call your name aloud and we will invite you to unmute. You should see a prompt on your screen to invite you to unmute and to speak. I may not go in order necessarily, but for the most part, we'll follow that. And because so many want to speak and we only have, we have a certain amount of time for this meeting, we'd like to ask that you provide comment in no more than a minute and a half. And that is just so that we can hear from as many people as possible. I will keep a countdown clock, and I will quietly let you know when half of your time is up, and then when the 90 seconds is up, and we just appreciate people respecting that so others can speak. Okay, so I'm going to first turn to Cindy Young and ask our technician to invite her to unmute. Go ahead, Cindy, and please state your name and any affiliation that might be important for this comment.
Sure. My name is Cindy Young, and I am president of Healthy California Now. And I would like to thank the commissioners for meeting today and for allowing me to speak. And the pandemic has shown the biggest blemishes in our healthcare system. And as Carmen Constance spoke earlier, there are deaths that are happening in our state over COVID, and the blemishes of employer-based insurance. My daughter just got a pink slip along with a COBRA notice. Just bought a house in last June and is struggling to figure out what to do. Our healthcare system is not serving the people of California. And so we want to strongly encourage the Commission to advance a single payer system, but also to include advocates. We have folks who have been working on health policy for years, doctors, nurses,
20 seconds left,
and health technicians. So please consider putting us on your stakeholder groups. Thank you.
Thank you, Cindy, and thank you so much for respecting the time constraints. I know it's tough. We really appreciate that. We're now going to turn to Peter Shapiro and invite him to unmute. Peter?
Okay, I'm a member of the Healthcare Action Committee and also the California Alliance of Retired Americans, both of which are affiliated with Healthy California Now, and I'm the Labor Council delegate for Alameda County for CARA. And I just want to address what Jim Wood said. I'm well aware, CARA is well aware of the devastating budget crisis that we face in the state as a result of the pandemic. And to me, that's all the more reason why we need to stop throwing away money on private insurance, on duplicating features, on, there's on corporate hospital chains that to allocate money where it's not needed while rural hospitals go broke. Clearly a single finance, there have been study after study that shows that a single financing system, a unified financing system where public dollars go directly to providers saves enormous amounts of money, and we can't afford to wait any longer. That's it.
Thank you, Peter. Next, we're going to invite Joel Sarch to unmute.
Can you hear me?
Yes, please speak up, and if you have an affiliation, sir.
Yes. Joel Sarch, lay member of PNHP and a chair of a chapter of Healthcare for All. I think we're missing one thing that's not being said that trumps everything else. If my neighbor down the street gets sick, the chances are greatly increased that I'm going to get sick, especially in a time of epidemics and pandemics. Therefore, the most important thing is to eliminate any impediment to a person who needs medical care getting that care. Access is fine if it means insurance, but if you can't die, if you have to worry about a choice between paying a large copay, and $20 is a very large copay to people that I meet daily, and putting food on the table, you don't have access to health care. That's all I'll say for now.
Thank you, Mr. Sarch. Next, William Bronston. Dr. William Bronston, we're going to invite you to unmute.
Thank you. I'm a physician, and I want to say that there's an urgency because thousands and more than thousands of people are dying every day. And they're dying because they don't have insurance and because they're underinsured at the level of close to 37% of the people in the state of California. The pandemic has only aggravated and multiplied the problem. I'm absolutely in a knot about participating in this commission's proceedings because there is a certain level of theatrical naivete that is being engendered by many of the commissioners that they don't know how serious and how urgent the problem is, because the money is polluting and prostituting all decisions and creating a sense of possibility of delay. That delay has got to stop now. We need to make a decision about single payer, similar to what's happening all across the world and in the face of this devastating, savage, vicious disease that we're confronted by. And so I don't know whether to continue working
20 seconds.
with the commission or whether to somehow be more aggressive and participate in some kind of advisory structure. But this commission has got to get out of the way and let the governor establish universal single-payer healthcare in the state of California related to HR 1384, which is our gold standard. And
thank you, Dr. Bronston.
Yes.
Thank you so much. Randy Hicks, we're going to invite you to unmute.
Okay, I'm Randy Hicks of Californians for Disability Rights. I want to let you know that COVID has devastated.
Could you please speak up if you're able?
Yeah. The COVID has devastated the disability community, and it's hurt them very badly. And because of that, this COVID budget is going to end up cutting other state services across the board. So we'd like to see as a single payer healthcare system, because with that financing system, we would not have these devastating budget cuts and all the other services that could be funded. That's what I have to say. We had single payer, we have better budgets. Thank you very much.
Thank you. Craig Simmons, we're going to invite you to unmute.
Hi,
Hello.
I'm Craig Simmons. I became aware of the commission through Senator Tony Atkins' office. And I've been an advocate for a single payer plan for a long time. The Supreme Court actually approved the Affordable Care Act as a tax. So my background is that my first job out of college actually was with a Kaiser Family Foundation and Teamsters Union program to give multiphasic physicals to county workers all over the state of California. And the way it was financed was through a 1 cent per hour payroll deduction from the employers would pay, and we would do multiphasics, complete exams with physicians and technicians to all the workers, and then we send the results to their private physician within 2 weeks of the exam for further diagnosis and treatment. Now, if you take that 1 cent per hour and bump it up to 25 cents per hour, it comes out to $6 million an hour. That's revenue that we don't have. It would pay for everyone who wants one to go to a hospital or urgent care center and sign up for a multiphasic physical, further diagnosis and treatment. And it would accrue $48 million a week into the state treasury. That would be a perfect solution, and I'd like to pursue it further if somebody could get back in touch with me, or I can get in touch with you.
Thank you very much. Thank you.
Thank you.
Mark Van Landoot, we're inviting you to unmute yourself.
Good afternoon, Commissioners. Mark Van Landoot, Northern California. For what the Commission ultimately recommends and submits, I want to discourage any strenuous efforts to keep the private insurance sector included in the equation. These insurance companies add no value to healthcare. They are middlemen extracting wealth from the interaction between sick people and their doctors. They have been ripping off the system. They have been ripping off the state. They are the fragmentation for financing healthcare. We heard justified concerns about building workforce and infrastructure in rural areas. This is a real concern, but private insurance companies do not create that infrastructure. Only a single payer system could focus resources in such a way to deal with those problems. If we're going to move forward with a healthcare system that is equitable and universal, we must leave the private insurance companies behind. This pandemic is a terrible teacher. It doesn't listen to focus groups. Our neighbor's health is our health. I urge urgency. Californians' lives are at stake. California desperately needs your advocacy now. California needs a universal single-payer healthcare system. Thank you.
Thank you very much. Dr. Bill Honigman, We're inviting you to unmute.
Thank you. Can you hear me okay?
Yes, sir.
Good. Thanks. Yeah, I'm a retired emergency room physician from Orange County. I'm affiliated with Physicians for National Health Program and Progressive Democrats America. I'd like to thank especially Commissioners Consti, Shao, and Maria for their bold comments. We know that countless economic and other social science studies have proven a single-payer system will save money and save lives for California, which couldn't be more obvious now since we have all experienced COVID-19. Why are we not already moving forward with such a system? I believe the Commission cannot wait a day more, an hour more, or a minute more without taking action to move this forward now. Thank you.
Thank you very much. Marlene Gillespie, we're inviting you to unmute.
Hi.
Hello.
My name is Marlene Gillespie from Irvine, California. And I think we're all of us are on board with single payer. We have been for years. The majority of the population is, but it's not going to be the public that's going to have to lead this. It's very clear that it's going to have to be the business community, some large corporations, and we have a wonderful opportunity here in our tri-state of California, Washington, and Oregon to connect and educate and work with some key, more progressive corporations, large ones, to let them lead this. The public will follow. Having all these public testimonies at your meetings is not going to work. They've never paid attention to them. It's going to have to be the corporate leadership. And maybe picking somebody like also Charlie Munger, who's from, back east, and who is so pro that. And having some key leaders that people will lead, that will listen to in this.
Thank you very
They
much.
Lead this, and that gets us around our stumbling blocks of Anthony Rendon and Jim Wood, and it also gives a back to our governor to be able to move forward. It will prove that it saves the economy and it saves all elements of this country.
Thank you. Erica Ferriston, we're inviting you to unmute.
Hi, am I on?
Yes.
So I'm just feeling a little concerned that this commission, like the Los Angeles Police Commission, one that was appointed by the mayor, but is really just a protector of the police and a buffer between the people and the mayor and the board of supervisors who really call the shots here. Governor Newsom couldn't act. He could tap any legislator right now and demand a bill be on his desk. People have referenced 1384 as the gold standard. So I'm just really concerned that this commission, with the exception of a few on this board, is really just a distraction to continue the corporate healthcare that has been causing death, financial bankruptcy, and suffering long before COVID.
Thank you. Larry Woodson, we're inviting you to unmute.
Good morning, Larry Woodson, California State Retirees. I want to draw attention to an alarming trend in healthcare highlighted most recently in a May 13th article in NBCnews.com titled PE firms, private equity firms now control many hospitals, ERs, nursing homes. Is it good for healthcare? And a May 20th Bloomberg article, How PE is Running American Healthcare. PE giants Blackstone, Apollo, Carlyle, KKR, and more are buying healthcare operations at a rapid rate. $340 billion spent in the last 10 years to buy rural hospitals, physician practices, nursing homes, ER staffing, urgent care. PE primary mode is to buy, cut costs, and then sell for a profit. And I urge the commission to broaden their description and analysis of California healthcare landscape and incorporate and address obstacles to this trend that this trend poses to the accomplishment of its mission, which includes
20
quality
seconds.
healthcare for all. Thank you.
Thank you. Taylor Jackson, you can unmute.
Hi, this is Taylor Jackson with the California Nurses Association. In my comments, I wanted to drill down on a specific component of the draft report we are deeply concerned with. This is the consultant's reference to a flexible workforce and greater use of non-clinical providers on pages 75 and 79. These references are made in the context of an overarching argument for getting better value for California's current spending on public coverage programs by shifting to a capitated per member per month payment model rather than a fee-for-service payment model. Capitated payments are not value-based, they are risk-based and require doctors groups to become quasi-insurers. Greater use of non-clinical providers is not about value, it is about reducing costs by inappropriately substituting unlicensed personnel for licensed healthcare providers who lack the education and clinical experience necessary to provide quality patient care. It is upsetting and very dangerous to hear this commission would put costs ahead of patient safety. Thank you for your time.
Thank you. Alberta Savadre, you can unmute.
Hi, thank you, Commission, and I hope you become committed to what the public wants in California, which
Could
is...
you please speak up a bit?
Yes, can you hear me now?
Yes.
Okay, I hope the Commission becomes committed to what the public in California wants. We already know that the vast majority of Californians want a single payer system. The latest data point beyond all the studies that have been already made is that Bernie Sanders, who proposes Medicare for all nationwide, won the primaries in California. Beyond that, personally, I have been involved as a single payer activist since I sold a computer system to a large healthcare insurance company that eventually, when I met with their chief information officer, he told me they were going to use it to deny claims. So, you know, this is what a for-profit insurance industry is all about, how to make more money, not how to sell, not how to help people take care of their health care. Thank you very much.
Thank you. Paul O'Rourke-Babb, you can unmute.
Hello, everyone.
Hello.
So I want to start out by saying that I've been a family nurse practitioner for 34 years, almost all of that time in rural areas. And the structural and institutional racism and classism that exists in our society is probably the most painful manifestation of one of the aspects of our healthcare. But I want to say that I bear witness on a weekly basis to the disaster that we call our insurance system. The pain and injury to my patient population is real and profound. I am a board member of the Butte County Healthcare Coalition. I'm also have been for more than 20 years a nursing member of the Physicians for National Health program. The lack of access caused by the private system we have now due to costs and extremely complicated portability causes tens of thousands of deaths each year and needed care not obtained for millions of Californians.
20 seconds.
I'm sorry?
I'm sorry, you have 20 more seconds.
Thank you. COVID-19 has made this so catastrophically and apparent, the inequities that we have in our healthcare delivery and planning. And we need to move to a publicly administered, taxpayer-funded, single, universal, and comprehensive insurance system. I want to agree with Dr. Bill Honnigan that the historical science has already answered the question of what we should do, and the costs are also answerable. And I would beseech the legislature to start taxing the people who don't pay taxes, the big corporate owners all over this state, the way they should be taxed, and we would have no problem funding this.
Thank you. Thank you very much. Jen Flory, you can unmute.
Hi, Jen Flory on behalf of Western Center on Law and Poverty. I would like to agree with the comments that were made about what COVID-19 has done in laying bare the health disparities that exist in California. But besides laying bare those inequities that we have, it also laid bare some of the things that we're able to do when there's a will. Recently, the Department of Healthcare Services was able to launch a COVID-19 presumptive eligibility program by which any uninsured or underinsured Californian could get testing and treatment for COVID-19. This sounds a lot like a single payer system for a single disease. So I would behoove the commission to think about, what does it mean if we are saying that poverty shouldn't preclude treatment for any disease, and healthcare should not impoverish anyone when they seek treatment? We're well aware of the federal obstacles to getting all of the waivers needed, particularly under this current administration, that would enable us to unify into a true single payer system. But in the meantime, we do need to think about how we can answer those questions and make sure that people are not being impoverished because they need healthcare, or they're not getting healthcare because they don't have money. So we strongly agree with Bob Ross's suggestions to talk to the communities that have been left out of our healthcare system, and then think of what we can do while we're working on unifying our healthcare system, because this is an emergency and we need healthcare disparities to stop now.
Thank you. Shirley Toy, you're next to unmute. Can we permit? Thank you. Shirley, go ahead.
Can you hear me?
Yes, we can. Thank you.
Yes. My name is Shirley Toy. I've been a nurse for over 40 years, and I'm a proud member of California Nurses Association and also an elected ADEM delegate to the California Democratic Party. Our current system has really hurt current healthcare workers and nurses. It's for profit, and they are not able to get the protective PPE that they need to take care of their patients. And there's no collaboration between the hospitals. Everybody's competing, and the prices has gone up. Single payer definitely will save money. I don't know why we want to pay more than we have to. We have no control of how much we have to pay. We're all hostages to increasing costs, whether you're an individual, an employer, a city, the county, state, and you know, nobody chooses to become sick. It just happens, and it's not like a car where you can get a lower version or a higher luxury car. Everybody needs healthcare when you need it. And this is a public health crisis, as COVID-19 has shown. When someone else is sick, it puts all of us at risk. And we really, it's insanity to just keep the status quo, to keep doing what it is, and thinking we're going to get a better solution. Thank you very much. We need single payer now.
Thank you. Kathy Rawlings, I'm going to invite you to unmute.
Good afternoon, and thank you for the opportunity to speak to the commission today. I'm currently a school board member in Carlsbad, as well as a member of Healthy California Now, and represent teachers for the California Teachers Association, and formerly worked for the California School Employees Association. So over the last 25 years, I've seen how our healthcare system has just robbed and stolen from our public education. We have teachers right now that pay over $1,000 a month and to pay a $2,000, $3,000 deductible to receive healthcare. And it takes this money out of our system and into the public, or into the profit centers that exist. So what I'm asking this commission to look at is to remove the profit motive, period. And I'd like to just quote a Star Wars that I don't believe that you were elected or appointed to watch people suffer and die. I've been involved in this fight for over 15 years, and we're still talking about it. Now is the time for action. We need to...
Kathy, I think I've lost you. I don't know if others have as well. Kathy? Kathy, can you just check your audio if you're on headphones, for example, or something? Just... Gosh, like ever, I mean, you're like in a tunnel. I can't hear you. Try again. I'm sorry, Kathy. For the sake of time, I'll move on to the next member of the public, and we can try to come back to you if there's time. Please do use the Q&A function to at least provide us with your public comment in writing. Sorry about that. Dennis Resendez, we're going to invite you to unmute.
Hi, my name is Dennis Resendez. I'm with the Democratic Socialists of America, Los Angeles, and the Democrats of Pasadena Foothills. I demand that this commission put a priority on the discussion towards the implementation of a Medicare for All single-payer healthcare program for all California residents. For the COVID-19 crisis, millions of Californians were uninsured or underinsured, especially in communities of color. That number is, I would assume, has grown significantly for the COVID-19 pandemic. And now with many have lost their jobs, and along with it, they've lost their their employer-based health care. Corporate health insurers prioritize profit over health of the public. We, the people, must be in the driver's seat when it comes to making sure all Californians are provided with guaranteed comprehensive health care, principally in communities of color. Doing so would also ensure that all funding for healthcare stays in the program, is not siphoned off by health care CEOs and investors. California is the 6th largest economy in the world, even larger than Canada. Yet Canada has guaranteed healthcare through a publicly funded program. California must be the leader in guaranteeing comprehensive healthcare to all its people, free of care with no premiums, copays, and deductibles. The only way to achieve this is through a publicly funded and directed Medicare for All single-payer program. Thank you very much.
Thank you. We have the next person is just has 0660547, so we'll unmute you. Please be sure to state your name and any affiliation. You just need to be able to unmute yourself now that you've been invited. There you go. Please go ahead with your name and any affiliation. I'm sorry, we can't hear you. Okay, my apologies. We'll have to move on. Nina Eliasov, please go ahead and unmute yourself.
Hi.
Hello.
I'm Nina Eliasov. I'm a sociology professor at USC, and I've been a healthcare activist since I realized how much better single payer is for everyone. There's over 22 studies and examples from other countries that show that single payer is cheaper and saves lives more than any other kind of system. We don't need focus groups to discover this. We already know it. It's out there, it's data we all have. So 2 comments about the focus group thing. The industry focus groups is just bizarre. To hold industry focus groups is to assume that we need the for-profit stakeholders to continue to exist, but we don't. It's cheaper if they stop existing, and it saves lives. Why do we want the pro-death industry to continue? That's one problem with the focus groups. But the other one about inviting random members of the general public would also be a disaster. We don't hold focus groups to learn how to build subway tunnels or to design engines or nuclear power plants or vaccines. That's not how you design a healthcare system. It's to find out how to market maybe, but not how to design a healthcare system. So we need single payer now. We already know that it works for all these different reasons. It's cheaper, it saves lives. People are dying now, we need it now.
Thank you very much. Corinne Frugoni, please go ahead and unmute.
My name is Corinne Frugoni. I'm a family physician up in Humboldt County, and I'd like to deliver a quote
from someone who's much more eloquent than myself, Dr. Don McCann, who is a member of PNHP, Physicians for a National Health Program, as I am as well. What he says is that when the proposed policy is right and the politics are wrong, you don't change the policy, you change the politics. That begins with people having a clear understanding of the single-payer Medicare for all model. If they understand it, most will demand it. And we want a one-tier system so that everyone has equal access to the highest quality health care. A one-tier system guarantees that everyone will have the highest quality health care. Thank you.
Thank you very much. Beatrice Sosa Prado, we're going to invite you to unmute. Go ahead.
Good afternoon. My name is Beatriz Sosa Prado, Executive Director of California Physicians Alliance. Since 1987, CAPA has been advocating for single payer in California. Today, I'd like to commend Carmen Comsty and Dr. Rupa Maria for their bold, progressive, and clear comments. COVID has proved that our current healthcare system is ill-equipped and dysfunctional. It's imperative to establish a unified system of public financing now. It is the only way that we'll have a healthcare system that is accessible, affordable, equitable, and that is high quality for everyone. Last year, CAPA released our roadmap to Golden State Care, which is a realistic, approachable, and it's a realistic and approachable plan that outlines how we can get from where we are now to a universal healthcare system. We look forward to sharing our roadmap with you and to being your thought partners of the Commission. Additionally, I'd like to echo everyone else's comments before me, but I'd like to add that we would like to see the Commission address private equity in healthcare and to talk about the importance of unlinking healthcare coverage from employment. Thank you very much.
Thank you. I'm going to give Eric Vance the ability to speak, and then we'll pass it on to Dr. Chen to weigh in. Thank you. Eric Vance.
Hi, my name is Eric Vance. I'm an organizer for the Healthy California Now Coalition. As Cindy Young mentioned, we represent millions of Californians from multiple areas of expertise and passionate advocacy who are carefully watching the proceedings of this commission. You might remember that I spoke at the first meeting in Sacramento about my mother's support of Medicare for All and her passing in a nursing home last Christmas. A single payer plan is the only solution to bring both a universal comprehensive standard of care to all Californians and to address racial and socioeconomic inequalities. Hundreds of thousands of people are protesting because they are fed up with widespread injustice. Today, we are fed up in particular with the healthcare insurance system and its tie to employment, and it's disheartening to see that the Commission's only advisory focus group so far are employers and providers. The Commission must include the working class, the true stakeholders of any future system of care. Please work with the Healthy California Now Coalition as we've continued to offer our breadth of expertise. You have a chance to change history and provide a measure of safety and justice for all Californians by recommending a single payer plan and listening to the public. Thank you to the multiple commissioners who have spoken in favor of these measures and have expressed concern with the consultant's plan so far. I trust so the rest of the commission will listen to their colleagues and to all of us rallying today to make our voices heard. Thank you.
Thank you, Mr. Vance. I actually want to turn things over to Dr. Chen now and check in at 12:30.
Thank you so much, Karen. I wanted to take a couple minutes first to thank the commissioners and the almost 300 members of the public who joined us today for what in many ways is a resetting of the commission in these tumultuous and unprecedented times. I wanted to highlight a few areas of commonality that I heard. I heard universal recognition of the devastation of COVID in terms of the health and economy of Californians, particularly our most vulnerable. I heard universal recognition of the need to address dire disparities among disabled, elderly, communities of color who are likely to be having a generational impact, not just for the people who are experiencing COVID today, but their families and their children and grandchildren. I heard universal recognition about some of the fundamental problems of our healthcare system, particularly around the reliance on employer-based insurance, fragmented financing, the variable role of the private sector, And I really heard a sense of urgency in terms of the need to move forward. From our conversation, and I just want to appreciate all the different comments and perspectives, it's really clear that we need to prioritize community voices, particularly those who are usually absent from these conversations, and go beyond kind of our usual conversations. It's clear we need to create an advisory process that includes broad stakeholder perspectives. And it also is clear that we need to use this window of opportunity before it closes. Hopefully it doesn't close, to move from the principles we've been discussing to something that's actionable and something that's practically implementable. So I just wanted to outline 3 next steps and then turn it over to Secretary Galley to close out. Very specifically, we're going to revisit our engagement prioritization and process to make sure that we do include the voices of Californians broadly. Think about the focus groups and also the advisory groups that we had talked about before COVID and kind of got restructured in our rush to kind of get things moving again. The second thing is we are going to extend the timeline for the report because a number of you have weighed in, and I know the consultants have taken much of it into account, but we want to make sure there's a process there. And then we are going to be setting up another meeting that will be longer than 2 hours. And again, I really appreciate all the commissioners who are able to stay on for the extra 30 minutes because we did really feel it was important to make sure the public had an opportunity, not just to write in their comments, but to have their voices heard. So those are some tangible next steps. And I just want to turn it over to Secretary Galley to, for last thoughts and to adjourn us.
Thanks, Dr. Chen. Thank you to all the commissioners, our consulting team, the nearly 300 or over 300 public participants to this meeting. I'm continued to be in awe and grateful of everybody's focus and resolve to keep us moving. I am also grateful for process and public process and the opportunity to have conversation and put things out and put a pause, just like we did on the commission, certain things today to really try to get it right. And I want to just emphasize that the goal of our leadership team and I as chair is to focus on product and process, to be inclusive and focused on populations that are commonly overlooked and unheard. And today, I think we hear a little bit about, or a lot about how we do that, and Dr. Chen summarized that nicely. I look forward to our next meeting. I think there'll be a lot to think about and do in between now and then. We will continue to work to bring back the momentum to this effort after this long pause and focus on the COVID response in California. And I know you all stand by ready to help both on the commission and across the public that's joined us. So with that, I'll let you get back to the rest of your afternoon. Thank you for extending a little longer, and we look forward to meeting and chatting again soon. Thank you.